Hello, everybody. My name is Virginia Kaklamani. I'm one of the co-directors of the San Antonio Breast Cancer Symposium, and I want to welcome you all to another edition of the SABCS Snippets. With me today, I have Dr. Lisa Carey from University of North Carolina. It's an honor to have you, Lisa. And as you know, a week or so ago, we had the approval of ribociclib in the adjuvant setting based on the clinical trial data from the NATALEE. So tell me what you think as far as when to use it. We have another CDK4/6 inhibitor, abemaciclib, in that space. So are you going to make your decisions?
Oh, thank you, Virginia. It's really kind of you to invite me here. I think it's wonderful to have options, right? And I think a couple of things. One is ribociclib is in fact approved in a slightly different patient population than abemaciclib is. So they both included and node positive disease, although in the ribociclib NATALEE trial, it was typically not just node positive, but also high risk node negatives, right? What we would call anatomic stage 2, which were not included in the abemaciclib approval. Conversely, it's a 3-year duration of therapy, where abemaciclib is only 2 years. So I think the magnitude of effect, which was just presented at ESMO a couple of weeks ago, is about the same at 4 years as the abemaciclib one was. And so I think we're seeing some similar efficacy, but a little bit of different tolerability, different duration. And so they are slightly different drugs, but it is great to have opportunities. I will, like many of you, probably opt for ribociclib, certainly in the node negative population where abemaciclib is not approved. And I think for many patients, the ribociclib is a little bit easier with less diarrhea, but you have more trouble with LFTs, with neutropenia, and you have to worry about QTc prolongation, so you do have to do EKGs.
So you mentioned the node negative, and obviously the NATALEE trial included many of those node negative stage 2s, not all of them. So here's a scenario that I actually had in clinic a couple days ago. 4.4 centimeter tumor, grade 2. The Ki-67 was 5%. I haven't done an oncotype yet, node negative, but I'm assuming the oncotype is going to be low. So technically it doesn't meet criteria for NATALEE. But would that be a patient, based on the data, that you would consider giving a CDK4/6 inhibitor, in this case ribociclib to?
I think I'm probably going to stick to the NATALEE criteria. I think these aren't easy drugs. The absolute benefit is somewhere just shy of 5% at 4 years. So it's a small but real effect, and certainly fits the clinically meaningful criteria. But when you start to get to lower clinical risk patients, then I'm going to be a little bit less, the likelihood of a clinically meaningful benefit is going to go down. There's a lot of cost. It's very hard for the patients, and it's a 3-year duration of a drug that requires them to come to clinic pretty frequently and can have some significant toxicity. So to be frank, I'm probably going to limit this to the higher risk node negative situation.
Yeah. And you mentioned the tolerability. Interestingly, only 60% of patients finished the whole 3-year duration. And I was looking, and even the AI, there were 30% of patients that did not complete the 5-year of AI therapy. So compliance is an issue, right?
Well, to be honest, compliance is an issue whether we're giving a CDK4/6 inhibitor or not. As we all know, adherence and persistence to endocrine therapy is a long-standing issue. It isn't made easier when you're adding a CDK4/6 inhibitor. And I think that you're making a very, very important point there. I mean, I do think that we have to have strategies for helping patients get through these long durations of therapy. And I think there are a number of trials from our health services colleagues that hopefully will help us with that. But it's a real issue, and this won't make it easier. And what you don't want is your patient to give up on their entire endocrine regimen because they don't like the CDK4/6 inhibitor. So we'll have to be very attentive to that.
Now, we've been using abemaciclib now for a couple of years. The patients that for some reason cannot tolerate the medicine, would you switch them to the ribociclib and then do a 3-year course?
I've done it already. I've been doing that I've actually been doing that. And, you do have to do a little negotiating to get it before the approval. So I've been doing it for exactly that reason. Once NATALEE had been presented, I use that as a tool if I couldn't give abemaciclib to someone with node positive high risk cancer, and I've actually had some reasonable success with that. So I can say not only would I do it, I have done it.
I'm glad I've done that as well. So perfect. Okay, wonderful. Well, thank you so much again for being here. Thanks everybody, and see you at another SABCS Snippet.
Thank you. Really appreciate being here.